Good morning, students. Welcome to Chapter 4. We're going to be covering communications and documentations on your EMT program. So, with that said, let's get started. Right. So, as we all know, the first part of our book and our reference material talks about national EMS standard competencies. You need to be aware that this particular chapter falls under preparatory. It also involves therapeutic communication with the principles of with students in a manner that achieves a positive relationship. And it also supports EMS communication because we all know that communication is needed for call resources, transfer of care of the patient, interaction within the team structure, EMS communication system, communications with healthcare professionals, and team communication and dynamics. It is also a very important part of documentation because with communications, we'll be able to record patient findings, principles of medical documentation, and also report writing will be understood. And also that medical terminology. You got to have good medical terminology based on national EMS standard competencies, be able to utilize foundational and anatomical and medical terms with abbreviations and written and oral communication with colleagues and other healthcare professionals. All right, so here we go, folks. One of three slides here on the introduction. In this particular framework, we're going to talk about the commission. Communication is the transmission of information to one another, whether it's verbal or through body language. Body language is considered nonverbal communication. We're also going to talk about the effectiveness of communication. Effective communication is the essential component of pre-hospital care. It is necessary to achieve a positive relationship with patients and coworkers. And then also verbal communications. What kind of skills do we have? And how very important they are in our day-to-day work routine. The verbal communication enables you to gather information from the patient and also bystanders. It also makes it possible for you to coordinate all the responders who are often present at the scene. And bottom line is that verbal communication is an integral part of transferring the patient's care to the nurses and physicians at the hospital. Right, second part of the introduction, documentation. Without communication and documentation, we wouldn't be able to pass along the information to the nurses and physicians that'll take care of the patient, nor would be able to create a record of that patient's treatment. The documentation begins with the written or electronically recorded part of the patient's permanent medical record. And what it does, it demonstrates that the care that you gave to your patient was appropriate. It also communicates the patient's story to others who may participate in the patient's future care. With this, we need to keep in mind adequate reporting and accurate records ensure the continuity of patient care. And also that complete patient records, they do a couple of things for us. One, they guarantee proper transfer of responsibility. They also comply with the requirements of health departments and other law enforcement agencies, and they fulfill your organizational administrative needs, such as the billing requirements and gathering that PHI or personal health care information that your company is going to need to bill the bill. It also drives the funding overall for EMS research. All right. So, last page about this particular introduction section 303, computer and radio and telephone communications. They're all a big part of what we do. They link us all together. They link the EMT to other members of the EMS, fire department, law enforcement communities. You need to know when you're communicating on this equipment what your system can and cannot do, how to use the system efficiently and effectively. All right, so 104 on therapeutic communications. What is therapeutic communications? Therapeutic communication uses various communication techniques and strategies. It utilizes both verbal and nonverbal. It especially encourages patients to express how they feel and achieves a positive relationship with each patient. The Shannon-Weaver communication model was developed to assist in the mathematical theory of communication for the Bell telephone labs in the late 1940s. This model still remains a valuable tool in understanding human communications. The sender takes a thought, then encodes it into a message, and then sends the message to the receiver. The receiver decodes the message and then sends feedback to the sender. That is how the model is structured. Right. In this figure, this illustrates how the Shannon-Weaver communication module works. As we can see here, if we take a look a little bit closer, we have that encoding phase. We have the message goes from encoding to decoding. It travels along. Feedback is generated, okay, and comes right back out and then re-encodes. So you have the receiver on one side and you have the sender on the other side. This is the Weaver model, Shannon Weaver model of communication. Very good stuff. And if you consider this is, was created back in the 1940s and it's still applicable today, that's pretty awesome. All right, this table on the screen lists factors and strategies to consider communication, especially when we're talking about age, you know, what's important, body language, your clothing that you're wearing, how you're dressed, culture, education, environment, maintaining eye contact. Be careful of your facial expressions. And sometimes we do still have to realize that some people will accept a female more than a male or a male more than a female. So sex does play involved in it as well. Also, your posture. This is the big thing about your body language and your voice tempo. Tempo and speed, definitely. Same in one thing, but speed being the same thing, and how clearly you speak. And then finally, the volume. Is it too loud or is it not loud enough? All right, so we're going to break down this just a little bit. Let's talk a little bit about age, culture, and personal experience. All right, so influence wise, influence how a patient, this age, sex, age, culture, and personal experiences definitely influence how a person communicates, especially when it comes to body language, eye contact. They are greatly affected by culture. In some cultures, people are encouraged to express emotion, while others view it as a sign of weakness. In other cultures, it's impolite to look away while speaking to somebody. Right, so tone, pace, and volume of language, it offers clues about the mood of the person communicating. It provides insight into the perceived importance of the message. And then we have what is considered ethnocentrism, considering your own cultural values are more important than those of others. Folks, I would definitely take a real close look at this because I've seen this on exams many, many times. So make note of that and explore your options on understanding what ethnocentrism is. Also, people tend to translate messages, then receive them in their own world view. Cultural impositions also force your values onto others. So be sure that you understand that one as well. That could be a very valuable test question as well. So be reading up on that, pretty closely. Healthcare providers may consciously, and this cultural imposition, healthcare providers may consciously or subconsciously force their cultural values onto their patients because they believe their values are better. Okay, let's talk about nonverbal communication. All right, there's three slides on this. Nonverbal communication will start with body language. Body language provides a lot more information than words alone. Even without exchanging any words, you should be able to tell the mood of your patient. Facial expressions, body language, and eye contact. Eye contact and body language is very, very powerful tools. So you need to pay attention to the body language, both your own and also that of your patients. Physical clues will help you and your patient to truly understand the message that's being sent between the two communicators. You can pick up a lot if they're standing there and they're angry, they're posturing, they're clenching their fists, they're clenching their teeth. That's an angry person. So be very careful on how you approach this individual. All right, so when treating a potentially hostile patient, it's very, very important that you understand and be aware of your own body language. You don't want to make them angry by the position that you're standing in. The sign of you with your hands on your hips just means that you're arrogant. And so it can be perceived that way and it can make them even more angry. So stay calm and try to diffuse the situation. Assess the safety of the scene always. Remember, you're number one in this, so make sure you protect yourself. Do not assume an aggressive posture. Make good eye contact, but do not stare. Speak very calmly, confidently, and slowly. And then never threaten the patient either verbally or physically. All right, some physical factors. Noise. Oh, gosh. People that are angry don't like any more unusual noise than has to be on the scene. So try to clear anything that dampens or obscures the true meaning of the message will get in the way. So try to, turn sirens off, turn the radio off. If you walk into a household and the radio is playing or the television is playing, turn it off because that way there can be good, clean communication between you and your patient. Literal noise. This is or sounds in the environment. Lighting, distance, physical obstacles may affect your communication. So be sure that you are close enough to your patient that there's nothing that's going to get in the way of affecting the projection of the communication you're trying to present to them. And then cultural norms. Cultural norms are things that are accepted within the culture that you live in. Those cultural norms often dictate the amount of space or proximity between people when communicating. Otherwise, people like their space. So be very careful. As a person, get closer and begin to, um, as this happens, you'll get a greater sense of trust. This is how you can establish it, but don't do it too quickly. Slowly move into that gaining of trust. Your gestures, body movements, and attitude towards the patient are critically important in gaining the trust of both the patient and the family. All right, so verbal communications. It is one of the most fundamental functions of an EMT. Okay. It's to ask patients questions. Fundamental. You've got to be able to do it. Open-ended questions require some level of detail in the response. Use this whenever possible. Example, what seems to be bothering you? That's just an open-ended question. It allows them to give you feedback. Don't interrupt their feedback. Make sure that you let them flow with it. Let them talk until they're completely finished and be an active listener. Shake your head and listen. Show that you're listening to them. All right, so closed-ended questions. They can be answered with very short answers. Response sometimes is a single word like yes or no. If use this if the patients cannot provide long answers. One of your examples is a patient who's short of breath. So if you're really short of breath, you're going to have a hard time answering questions. So an example with, are you having trouble breathing? Then they can give you a yes or no. The only thing is that when we ask these kind of questions, they may miss some important issues, especially if pertinent questions are not asked. So you have to be careful when you're using those closed-ended questions. Still try to make as much freedom of expression that the patient can give to you in order to help you ascertain what is wrong with your patient. All right, so communication tools. You can use a whole variety of different powerful communication tools when you're trying to talk to patients and gain that information. The first one being facilitation. You've got to be a good facilitator because this is encouraging the patient to talk more, provide more information. It's facilitating their language, but don't put words in their mouth. Pause. Pause is a good thing. It gives the patient space and time to think and respond. A simple pause would be, and then pick it up again, whatever your question may continue to be. That pause also allows you just a brief second to gather your thoughts about the question you're about to ask. Also, reflection. Reflection is just simply restating the patient's statement that they have made to you to confirm your understanding of what they just said. You got to be empathetic. Being sensitive to the patient's feelings and thoughts is what empathy is all about. So be empathetic because if you are empathetic, they're going to see that as well. If you're not, they're going to shut you out. And every now and then you got to clarify. So asking for clarification is nothing wrong with that at all. Ask the patient to explain what he or she meant by the answer that they gave. Confrontation. This can be done in a proper way. It's making the patient who's in denial or in a mental state of shock focus on urgent and life critical kind of issues. So every now and then you may have to confront a patient to answer what it is that you're asking. I need for you to answer me this now, answer this question now, because many times they'll dance around a circle trying to answer that question, but they won't be very clear on it. And if it's life-threatening, make it very clear and have them respond to your question, whether it's a closed-ended yes or no or an open-ended explanation. So interpretation, that's restating the patient's complaint, confirm your understanding. Explanation is providing that factual information to support the conversation. So you're going to explain back what it is that the information that's given. So you make sure that it is factual. Finally, summary. In summary, you're providing the patient an overview. Don't make it too long because otherwise it would be very confusing. But it's an overview of the conversation and the steps that you're going to be taking to help them out. Right, so interviewing techniques. We have to be good at this. When interviewing a patient, consider the careful use of touch to show caring and also compassion. Touch is a powerful tool. When I walk up to a patient, I usually generally introduce myself and say, "Can I help you?" When they say yes, I have now received express consent. At that point, I'm going to attempt to put my hand on their shoulder and my hand on their wrist, just like you see here, because the hand on the wrist, I'm actually taking their pulse. I want to see if they have a radial pulse. That touch is a very powerful tool. It helps to ease their pain and comfort them and get them comfortable with you. Use it consciously and sparingly. If you're going to touch the patient, approach them slowly and touch the patient's shoulder or arm respectfully and consider holding the patient's hand. Avoid the patient's torso, chest, or face simply as a means of communication because these areas are often viewed as intimidating. So, you know, get away from those areas because it may make them jump or, create a negative response that you don't want. Okay, so interview techniques to avoid. Providing any false assurance or reassurance is a very, very bad plan because if it comes back that it was false, then they're never going to trust you again. Giving unsolicited advice, just don't do it. Don't tell them that when this is all done, they should go to medical school and become a doctor or any of those kind of things. If it's not unsolicited, then don't give the advice. Asking leading or biased questions is always a bad plan because you don't want to lead or you don't want them to be judgmental of the information you're trying to provide. Talking too much, blah, 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 blah. It'll absolutely drive a patient crazy. And some patients, it actually may make them angry. So try to avoid that. Interruption. Don't do it. Let them finish their sentences. Don't put words in their mouth. Don't interrupt them while they're talking. Also, the using of why questions. Why questions are so open-ended, and it may take forever for an explanation to get out, and it may end up causing the patient just to get angry. Using authoritative language. If you don't do this, I am going to tell your mother. That's kind of a bad expression, but anyhow, don't be authoritative. Don't use that kind of language because you're definitely going to turn your patient off. Always speak in professional language, but not professional jargon. If you're using all these different medical terms, it's just they're not going to understand. It's going to confuse them, and it may mislead them into thinking that something's very, very wrong with them, or that they're going to be completely okay, or it may make them angry. So just avoid that. Right. So presence of family, friends, and bystanders. Um, they could be valuable, or they may not be valuable. They could be valuable during that patient interview process. You need to make sure to allow the patient to answer if he or she is able and wants to, even if the well meaning family members attempt to answer for the individual. Let the patient answer for themselves, no matter what the age group is, unless they're in like a toddler kind of age, that's a whole different story. Don't be afraid to ask others to step aside for a moment while you talk to your patient. Because remember, this is your patient. Your relationship is with you and the patient. You may need to decide if having a family and friends nearby will help or hinder care. If you think it's going to hinder care, let's isolate that situation. If the family has a problem leaving, then just go ahead and load your patient up onto the stretcher and take them into the ambulance and close the door. That way you can have your quality time with your patient. All right, a few golden rules to remember to help to calm and reassure patients. One, you need to make and keep the eye contact at all times. Two, you need to provide your name and use your patient's proper name. Don't call them sweetie, honey pie, dude, anything like that. Just inappropriate. Tell the patient the truth. Use language that the patient can understand, and be careful what you say about the patient to others. And most definitely be aware of your body language. If you're not aware of your body language, you're going to end up coming over as intimidating or threatening, and your patient's not going to respond very well to it. Hey, another golden set of golden rules, two out of two. Um, in your speaking capabilities, you need to remember to speak slowly. Be very clear and be very distinct on what you're trying to say. This way, it won't be misinterpreted and will be heard correctly. If the patient is hard of hearing, face the patient so he or she can read your lips. Allow the patient time to answer or respond, and then act and speak in a very calm and confident manner. All right, so emotional intelligence. Emotional intelligence is your people skills, okay? Your people skills and their people skills. It is the ability for to understand and manage your own emotions and properly respond to others' emotions. It allows you to help diffuse conflict, build a rapport, and communicate more effectively and manage difficult situations. Some of the attributes of emotional intelligence are one, self awareness, which is the ability to recognize your emotions and how they affect your thoughts and behavior. Two is self regulation. This is that ability to control impulsive emotions and behaviors, to manage your emotions in a very positive way. In somebody's worst day, you don't want to fall apart on them. You don't want to fall to pieces and then lose control. So you want to be able to be self regulating. Motivation. It is the ability to motivate yourself and others in a positive direction. Empathy. We talked about that once before. The ability to understand the concerns and emotion and needs of others by picking up on communication and social clues are very, very important. So, social skills. It's also the ability to develop and maintain a positive rapport and relationship through effective communication. All of these are very, very important for the EMT to be able to communicate and manage their patient care effectively. Right. So, improving your own emotional intelligence, we need to understand this concept. From time to time, we need to assess how we react to a stressful situation, how we manage our frustration and work on staying calm and control when faced with minor irritation. We need to practice mindfulness. Mindfulness is that focusing of our attention on the present moment without any blame, without any judgment of yourself or others. And you need to take responsibility for your actions. Consider how your actions will affect others. All right, so continue on with emotional intelligence. We need to think about our behavioral change. It's a kind of a stairway model. This was developed by the Federal Bureau of Investigation, or FBI, to manage hostage situations and adapt to most crisis situations. First thing is employing active listening. And active listening displays to um, the hostage or displays to the hostage taker, the kidnapper, that you're listening to what they got to say. It's the same thing with your patients. If they believe that you're actively listening, or they believe that you're listening through active listening techniques, otherwise shaking your head, maintaining eye contact, and making gestures that let them know that you're a part of this conversation, it's going to diffuse them and make them feel more confident in what you're going to do for them. Also displaying empathy. That's your facial expressions, your size, things that you can do that cue them in that you're listening and that you're empathetic to their situation. You need to build that rapport, make them feel safe, make them feel wanted, make them feel important, and that their situation is number one in your life at that moment. Also exert influence. You need to be able to exert yourself in the fact that you're able to influence a situation to change it to a positive way so that they feel more comfortable with working with you and with having you as their patient caregiver. Also initiate behavior change. From time to time, you have to steer them into another direction. If you have somebody that is getting louder and louder and louder, say, whoa, whoa, wait, 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 I understand. Can you bring it down just a little bit? And then, that way I can hear it better and so can you. And so that's an initiation of behavioral change. It helps a lot. All right, so communicating with older patients. Well, first off, please don't think that all older patients can't hear. That is not the truth. They might think that you're yelling at them if you raise your voice. So, number one, you need to identify yourself. Hey, my name is Jeff. I'm a paramedic. Can I help you? Present yourself as confident, confident, and caring. Don't assume that an older patient is senile or confused. That just is the bad plan. Very, very bad plan. Notice in this photograph here that this gentleman here, he is holding her hand, okay, has her by the elbow. He does have some mask protection on, so maybe he's instilling some confidence there that, I'm listening to you and that you're sick, and I'm, protecting you from any harm that I may cause you by giving you some respiratory infection. I mean, he very sincere. Notice how he's dressed. He's wearing a very clean uniform. It's buttoned up, and he's displaying confidence when he's talking to this elderly person. All right, you may encounter hostility with patients. You just never know. Um, the elderly patients sometimes, because of senility, may have some hostile, or some irritability. And then definitely they could have some confusion. Don't assume this is normal behavior because it may not be. You need to find out from, family members and caregivers, is this normal? Is this abnormal? Assess for signs of hypoxia, excessive signs from maybe cerebral vascular accident or stroke, CVA, potential for drug overdose, infections. Infections is a big one. Patients who have urinary tract infections, which you may not be aware of, or the caregiver may not be aware of, can cause a lot of different problems of, irritation, hallucination, those kind of things. Altered mental status, hypoglycemia. We need to make sure that we understand that they are or not hypoglycemic. The only way that we can do that is do a blood glucose check and, just something is relative is that only those patients that are altered mental status should have blood glucose checks. That way, we're establishing that right on early. We don't forget that. So, hyperglycemia, maybe the sugar's too high, or insufficient perfusion. You could be going into shock. Approach an older patient slowly and calmly, and then allow plenty of time for the patient to respond to your question. All right, so communicating with older patients continued, watch for signs of confusion, anxiety, or impaired hearing or vision. Either one of those can come to play in your assessment of the geriatric patient. The patient should feel confident that you're in charge and everything possible is being done for him or her, and be patient with them. Again, let them answer, help them up out of their chair, help them be seated, whatever is comfortable. That will be able to continue your exam confidently and safely. Right. So with older patients, we need to make sure that we understand that they often don't feel a lot of pain. If they're diabetics, they could have general neuropathy because of the changes in sugar patterns. They develop neuropathy in their hands, their feet, and general neuropathy themselves. They may not be able to feel pain like you and I can. They may not be fully aware of important changes of their body system. You may be especially vigilant for objective changes. Again, I've had patients that thought that they were 21 years old and they're in their 90s. That's how they see themselves. I mean, this is very possible. So don't negate that. Don't just downplay that. Go along with it and try to get as much information you can to be as helpful as you can to your patient. All right, so last slide on geriatric communication. When possible, give the patient time to pack a few personal items before leaving the hospital. And if they're having a hard time, help them out. Ask them what they're going to need, where it's located, and try to get that, together for them. Locating any hearing aids, eyeglasses, and dentures before departure is very, very important. They're going to need these at the hospital. Older patients are often worried about the safety of their own home, their valuable items, and their pets. So share these concerns with the person assuming care of the patient at the hospital to ensure that this is taken care of, that the family is contacted or some kind of neighbor is contacted or caregiver is contacted so they can help secure their home and take care of their pets. Okay, communicating with children, one of four slides. This can be a real treat. With children, and I love kids, I love them to death. They're so much easier to get along with other than adults, because adults have so many different problems that children, basically, it's about their initial fear. But once they get over that initial fear, it's over. Fear is the most obvious and severe in children. When you're talking to them, they may be frightened by your uniform, the ambulance, a crowd of people gathered around them, could be a whole bunch of things that goes on top of whatever the emergency is. So fear is that number one that you got to break the ice with. So how do we do that? Let the child keep a favorite toy, a doll, security blanket, whatever makes them comfortable. It's good. It's positive. If they need to hang out with mom, you know, during your assessment, there's nothing wrong with that. If possible, have that family member or friend nearby. If practical, let the parent or guardian hold the child during the evaluation and treatment. Be honest. Children will easily see through a lie or deception. So make sure that you never, never, never fib or lie to a child. They'll catch you on it, then they'll never test you. Tell the child ahead of time if something's going to hurt. You have to put their arm in a splint, or you have to um, stop bleeding. Make sure to tell them that this may hurt and that you're sorry, but you'll get it done as quickly as possible. And then, of course, respect a child's modesty. Keep them covered up as much as possible and be understanding that, especially of the age group that you're dealing with or the developmental age of the child. All right, speak in a professional yet friendly way. Use appropriate tone. and vocabulary. Don't overspeak, what the age of the child is going to be able to understand. And maintain that eye contact. Then position yourself down at the child's level. Don't tower over the child. That's what I like about this particular um, photograph is that notice that the child is sitting on the ground and the caregiver or the EMS worker, the paramedic, EMT, has gotten down to their level to be able to talk to this child and not or stand above him. This makes this much more acceptable, and the child's going to feel a lot more comfortable this way. Right. So when you have a hearing impaired patient, it's very important to understand that communications with patients who are hard of hearing is not impossible. You just need to work with it. Most people who are hard of hearing have normal intelligence and are not embarrassed by their disability. So position yourself so that the patient can see your lips. This will allow them to read your lips. You need to be very slow and pronounce your words. Don't overpronounce the words because they won't understand that either. Allow them to see your lips move in a normal fashion, and they should be able to tell you. They're very, very good. Many of these patients are very good at reading lips. They also may have hearing aids, so be careful that they're not lost during an accident or fall, and if they are, you need to recover them and then get them back to the patient as soon as possible, and then they can reinsert it in their ears. They may be forgotten if the patient is confused. So if the family's there, ask the family about the use of hearing aids. Does your loved one here use hearing aids? So steps in officially communicating with patients who are hard of hearing. Again, you can have paper and pen available just in case they need to write. Like I said, they usually have normal intelligence, and they'll be happy to write down on paper and pen if especially if their hearing aids aren't working. If the patient can read lips, face the patient and speak slowly and distinctly. Never shout at them. Right. So some simple sign language. Listen carefully, ask short questions, and give short answers. Learn some simple phrases in sign language. It can definitely be useful to know the signs for sick, hurt, and help. Right. So now the visually impaired patients. Number one, so this is a person that could be partially blind or totally blind. Ask the patient if he or she can see at all. Visually impaired patients are not necessarily completely blind. Many can perceive light and dark or even can see shadows and movement. So expect the patient to have a normal intelligence and explain everything that you're doing as you're doing it. Make sure that you're staying in physical contact with the patient as you begin your care. If the patient can walk to the ambulance, place his or her hand on your arm and guide them to the ambulance. You need to transport any mobility aids such as a cane or anything that they may use to go with the patient to the hospital because they're going to need it, once they're there. So make sure you take it with them. Right, so guide dogs. And I've had a lot of questions about guide dogs and about um, service animals, comfort animals, that kind of thing. They're easily identified by their special harnesses. If possible, transport the dog with the patient or the comfort animal, whatever it is. If at all possible, please do that because this will alleviate stress for both the patient and the dog or the service animal. Guide dogs are trained not to leave their masters, so if you separate the two of them, the dog's going to have some really severe problems with that. Otherwise, arrange for care of the dog. A conscious patient can tell you about the dog and give instructions for his care. If not, please be sure that you make the arrangements that, the dog or the service animal or the comfort animal is going to be taken care of properly before leaving. All right, so non-English speaking patients. Communication with non-English speaking patients can be challenging at best. You must obtain a medical history even though the patient does not speak English. You cannot skip this step, remember that. So find out if the patient knows a few English words or phrases. Then you can use short, simple questions, point to parts of the body and say hurt, and then make a facial expression, those kind of things, and you might be able to get the information. Seek out a family member or a friend to interpret until a professional interpreter is available. Consider learning some common phrases in another language that's used in your area. So seek out what exactly is in your area for different types of language. Pocket cards that show the pronunciation of terms are definitely available. Your smartphone or an app or website can help you to translate. Remember to request a translator at the hospital once you arrive. If you can, if you're calling in your report, ask them to have a translator available in whatever language it is that your patient speaks, if you know what it is. So be very, very helpful to do so. That way they can be prepared to receive the patient with an interpreter in place. All right, so mission critical communication. Mission critical communications are any communications where disruption will cause in the or result in the failure of a task at hand. So a shared mental model that comes with critical communications. A mental model is the picture individuals have in their head of what's going on. For any team to work effectively together, all members must share the same mental model. And if they're not, then we're not on the same playing field. So we need to regroup and do what we need to do to make sure that the mission is deemed for success. And that's the direction that we're headed. To build a mental model, the following questions have to be answered to make it happen. The first one is, what is the focus priority for the patient? Otherwise, what is the crux of the problem? Once we're working with what we call that differential diagnosis, whether it's asthma or whether it's congestive heart failure, we can begin to put together that mental model. We also need to know the history of prior care. What got us to this point? And then what is the patient's current state? That's telling us where are we now? Then what is the patient immediate needs? Otherwise, what is the very next thing that needs to happen for this patient to improve or to get out of this life-threatening event? So answering the four questions quickly and efficiently will help to avoid errors and any misunderstandings. Patient care handover. Okay, so you've done a real good job. You've communicated with your patient. You've done everything you should be doing. Now we need to do a patient handover to somebody of a higher level of care. So, effective communication between the EMS providers and other healthcare professionals in the receiving facility is essential to efficient, effective, and appropriate patient care. Patient care handover is the transfer of pertinent patient information and the responsibility for patient care. So, A, okay, number one, communication failures between the reporting providers and receiving providers is a source of medical liability for the provider and organization. And B, it sure does make you look unprofessional when you can't effectively communicate with that receiving facility. So have your ducks in a row. Make sure that you have all the information in front of you. Don't rely upon just strictly memorization. Have some kind of short tool like a field assessment tool that you're going to make some notes on so that you'll be able to effectively pass all the information to the caregivers. So, giving that handover report, first off, initiate eye contact. Making eye contact with the person whom the patient's being transferred is going to gain their respect for number one. They're going to be prepared, seeing that you have a confidence enough to make that eye contact with them. And also managing the environment. Whenever possible, try to minimize the noise and interruption and distractions while you're given the verbal report over to the receiving facility. You still need to make sure that you ensure of ABCs. If there's a priority critical care that must be initiated or continued, it must be immediately conveyed and addressed by the receiving clinician or team. If a patient needs to, you know, be put into a room because, there's a possibility, that they may have a mental outburst, may become agitated or aggravated, you need to make sure to relay that to the team immediately. Right, so you need to provide a structured SBAR: situation, background, assessment, and recap and treatment. That is one method. And then SBAT: this is a situation, background, assessment, and treatment. Whatever you're using, you need to provide documentation. The verbal report should consist of the patient's priority condition, priority care, current state, and immediate needs. Right. So receiving the handover report. So you're on the receiving end. Okay. Maybe a first responder or an EMR is now going to hand their patient over to you. So how do you receive it? Receiving is pretty simple. Again, same plan. Maintaining eye contact, manage your environment, ensure the understanding, and make sure that you actively listen to what is being given to you, and let the EMR that's turning over to you be able to deliver their information, completely. Don't interrupt them. And then summarize at the end with the first responder. Gather any supplementary patient documentation, and you'll be good to go. And so written communication and documentation. Written communication is what we call the PCR, or Patient Care Report. PCR is also known as that pre-hospital care report as well. Either way, patient care report, pre-hospital care report can be called either way, but it is a legal document that's used to record all aspects of the care of your patient received from the time of initial dispatch to the hospital arrival. There are two types of written PCRs. It's a written PCR or electronic PCR. The PCR serves six functions. It provides for a continuity of care. It is a compliance document and legal document. It provides for administration information. It also allows for us to get reimbursement from insurance companies and ultimately from the patient for the services that were delivered. It can also be used as an education model. That information may be put into a quality improvement process, so it can become a part of the educational model for training on, you know, different EMTs and paramedics that come into the system that have not experienced that kind of patient before. It's also utilized for data collection for the continuous quality improvement process. So information, some of the examples of the information collected on a PCR would be your chief complaint, mechanism of injury and illness, level of consciousness to include AFPU or mental status, vital signs, initial and ongoing assessment, also patient demographics such as age, gender, ethnic background, and then of course the transport information, how the patient was moved and for the reason or the reason for the destination of choice. It is a legal reckoning or accountability of your treatment and transportation of somebody. And it should be detailed right down to ensuring that you put the straps on the patient during transport on the stretcher. A lot of administrative information for use in billing is on PCR as well. Also for research and quality improvement. This information can be gathered from the PCRs. Some examples: when the incident was reported, the EMS unit was notified, when the EMS unit arrived at the scene, when the EMS unit left the scene, and then when the EMS unit arrived at the receiving facility, the patient care was transferred, and the unit was back in service. This tells a provider a lot about his or her service, how effective it functions in each manner or phase of the call, because all of these are phases of the call. Right, so types of form. Most PCRs are completed in electronic format these days. They're referred to as ePCR. Virtually all are designed to comply with NIMSY's data collection requirements. EPCRs allow for patient information to be transmitted directly to the hospital computers and may be integrated with the patient's electronic medical record. And then the narrative section of the PCRs is very, very important. It is most important and it should be as complete as possible. Right, so standardized narrative formats. The two most common narrative formats used in healthcare is chart and SOAP. So the chart method, it stands for Chief Complaint, History, and Physical Examination, Assessment, Treatment, and Transport. Begin with the dispatch information, then the chief complaint or chief concern. It states the condition most urgently require EMS intervention. It also includes history. It also includes the details relating to the current event and the patient's medical history prior to this event. The details come from the patients or others on the scene, from dispatch, or from the patient record. Also, the assessment. The assessment describes all the assessments you perform on the patient to include vital signs and the physical examination. And also treatment. Treatment to include also medication. It is the detail of all interventions that were performed. And then finally, transport. This explains how the patient was moved to the ambulance, how the patient was transported, the position that they were transported in, and that they were secured, as I mentioned earlier, to the stretcher. Also, whether emergency lights and sirens were used, and where the patient was taken, including the room number, which is very, very important. And I also emphasize that the name of the person whom the report was given, who accepted the patient's care. It was Nurse Davis. It was, Dr. Filardo, whoever it was, who was the person that received the care. And one last thing that I would like to emphasize as well, if the patient has any belongings, make sure you say what the belongings were and who they were left with or where they were left at. If they have no belongings, say patient had no personal belongings. Those are just good quality statements at the end of your EPCR that makes things a lot clearer if there's any discrepancies. All right, so the other format is SOAP. SOAP includes the four components: subjective, which includes information by the patient or others in the scene, such as chief complaint, events leading up to the incidents, and mechanism of injury and past medical history. Subjective, plain is simple, is anything that um, you have been told when you arrive on the scene. So it's what has been spoken to you, what is being told to you. The objective is details. This is details. This is what you see. Objectives is what you see. It includes the details you gather primarily through the patient assessment, such as vital signs, physical exam findings, and other measurements such as blood glucose and oxygen saturation. Assessment. What is your assessment of the patient's condition? It's a summarization. It's where you're going to summarize key findings and, if appropriate, provide your impression of what the patient's problem is, such as pain in right lower leg, possible fracture of lower leg, or altered mental status, possible stroke due to paresthesia. Whatever it is that you choose to put in there, but it's a very short and sweet summarization. It's usually no more than 4 words or 5 words. It's just a summary of what you believe, your assessment of what the patient is. And last, plan. Plan is what you're doing for your patient, what your treatment is, what your on-scene treatment is, what your en-route treatment is, and what your hospital arrival disposition is. So you're documenting treatment that's provided for the patient in all 3 phases of the call. Right. Regardless of the method used, the PCR narrative section should include at least the following events, or at least the following components: time of events, assessment and findings, emergency medical care provided to the patient, changes in the patient's condition after the treatment you performed, observation at the scene, final patient disposition, any refusals of care, and then staff person who continued the care. Who did you turn the patient over to? In written documentation, you need to avoid radio codes and abbreviations. No one knows what they are. They're just completely unacceptable because when you're reading it, you're not going to know what it is. Once the complete, distribute all copies to the appropriate locations. Right, so healthcare or health information exchanges, or HIES. Healthcare information exchanges, they ultimately improve the sharing of data between EMS and other healthcare providers. It allows EMS providers to access relevant health data and avoid unnecessary duplication of effort in data entry, and also view patient outcomes related to hospital care. Ultimately, it allows EMTs to contribute and access the electronic healthcare information on both a regular basis and during times of disaster. So this is a unified database on all patients. If you have it within your state, that's wonderful. Not all states have this, but it's very, very effective, and it keeps from duplicating the efforts of, you know, getting information. It's, by the way, it's constantly updated every time the patient is seen by either EMS or by the hospital. Right. So about these HIEs, or HIES, they allow for a SAFAR framework. SAFAR framework starts with search. So EMS providers can search for hospital and other records that will help make the treatment and transport decision. And then alert. It alerts hospitals. It allows hospitals to be notified of incoming EMS patients with automated systems that populate on the emergency department dashboards with information entered by the EMS field. And it also files. It files the data in an EMS electronic patient care reports. They get incorporated directly into the patient's long-term health records, so it will follow them through their continuum of care. And finally, reconciliation, or reconcile. It gives feedback on outcomes and other hospital data that's provided to EMS agencies for billing and quality improvement purposes. And so reporting errors. If you leave something out or record it incorrectly, do not try to cover it up, plain and simple. Falsification of records is going to get you in trouble. It results in poor patient care. It may result in suspension or legal action, so just don't do it. Always be truthful in your reports and be clear and concise and tell everything. Don't leave anything out. Do not falsify any records whatsoever. It could definitely end your career. If you discover an error as you are writing a report, if you're on a handwritten report or any handwritten document, all you have to do is just draw a single horizontal line through the error, initial it, and write the corrected information next to it. Do not try to erase or cover up the error with correction fluid. If an error is discovered after you submit your report, follow the same process. Add a note with the correct information. If the information was accidentally omitted, begin a new section with the word addendum and add to the new information, then add the date of your initials. In electronic or EPCR world that we live in, this is usually not an issue because you can go back and modify your report. But what happens is if you go back, you're making an addendum to the record. You won't be allowed to go back and alter the record once you submit it. Because once you submit it, it's been submitted. But you can go back and you can create an electronic addendum showing your mistake or telling about your mistake, and using that as a correction of that error. Right, so refusals. Document your refusal of care. Refusal of care is a common source of lawsuits. It's one of the reasons why I hate refusals. I really don't like using them. If you call 911, we're going to the hospital. It's going to take a lot for me to initiate a refusal. But if you do, thorough documentation is crucial. Document any assessment findings and emergency medical care given. Have the patient sign a refusal of care form. Have a family member, police officer, or bystander also sign the refusal of care form as a witness. Depending on local requirements, the PCR might contain a complete assessment that you have to perform, evidence that the patient is able to make a rational, informed decision, and then discussion with the patient as to what the care and transportation EMS recommends. And if they refuse it, what could be the consequences? So, that discussion point is going to be with the patient of what could happen. Always encourage them that, if they are refusing, that if they feel ill again, to activate 911, to feel free to do so. In that discussion, also should be with family or friends or bystanders to try to encourage the patient to allow for care and also transportation. Also have discussion with medical direction based on your needs, on what you believe should occur for the safety of the patient. Remember the EMT creed, do no harm. Providing the patient with other alternatives, for example, going to see his or her family doctor, or having a family member drive him or her to the hospital. Make sure that they know that the willingness of you to return, the willingness of EMS to return. Make sure you get signatures and complete the PCR so that when it gets filed, there's no blanks at all. There's a clear picture of why this refusal occurred. All right, so special reporting situation. What this means is this some event has happened and you have to report it to certain authorities. So they all depend on local requirements, but some of the most common ones are gunshot wounds, dog bites, certain infectious diseases, suspected physical or sexual abuse, and then also MCI incidents. Right, so communication systems and equipment. Well, there's a whole bunch of them out there. Radio and telephone communications link your team with other members of the EMS, fire, and law enforcement communities. They help the entire team to work together more effectively, and they provide an important layer of safety and protection. First off, we have a base station radio. A base station is any radio hardware containing a transmitter and a receiver that's located in a fixed place. Then a two-way radio consists of a transmitter and a receiver, but may also be equipped with one multi-channel and several single-channel receivers. A channel is an assigned frequency or frequencies used to carry voice and or data communication. A dedicated line, also known as a hotline, is used for specific point-to-point contact. So, a couple slides here. Mobile and portable radios. What's the difference? Well, a mobile radio is installed in a vehicle. Mobile radios are used in the ambulance to communicate with the dispatcher and also medical control, and also each other. An ambulance often has more than one mobile radio. Okay, so portable radios, exactly what it says. They're portable. They're handheld devices. Portable radios are definitely essential at the scene of an MCI. When away from the ambulance, a portable radio is helpful to communicate with dispatch and also another unit and medical control. Repeater base system. Repeater is a special base station radio. It receives messages and signals on one frequency and automatically retransmit them on a second frequency. This allows for two mobile or portable units that cannot reach each other to directly communicate using greater power and a bigger antenna. So this figure on this slide illustrates how a repeater-based system works. A message is sent from the control center to the transmitter by a landline. The radio carrier wave is picked up by the repeater for rebroadcast to outlying units. Return radio traffic is picked up by the repeater and rebroadcasted to the control center. Nice little diagram explaining what a repeater system is. It also works both ways too. Repeater system can be also in your ambulance to boost the signal of your portable radio when you're away from your ambulance. So, other equipment, digital equipment. Telemetry is one of those things. It's where we allow for electronic signals to be converted into coded audible signals. The signals can be transmitted by radio or telephone to a receiver with a decoder at the hospital. Data from cardiac monitors can be transmitted via Bluetooth enabled mobile devices to monitoring centers. And digital signals are also used in some kinds of paging and tone alerting type of systems. Cellular and satellite telephones. EMTs often communicate with receiving facilities by cellular telephone. Satellite phones or sat phones are another option. A scanner is a radio receiver that searches or scans across several frequencies and then stops whenever it receives a radio broadcast on that frequency and continue once the message is complete. Conversations can easily be overheard out there in the airwaves because many people have scanners, so they're listening in to conversations that are going on in their neighborhood. Other communication equipment, well, ambulances usually have an external public address system that you can talk through on a microphone and it'll broadcast outside of the ambulance. EMS systems may use a variety of two-way radio hardware. Simplex is the push to talk and the release to listen. Duplex is simultaneously talk and listen. You got to be careful. If you're on duplex, they can hear anything that you're saying. Multiplex. This utilizes two or more frequencies, which enables more than one transmission to occur simultaneously. Med channels are reserved for EMS use. These channels are usually on the 400 bandwidth side, and they're only used for EMS. Trunking. Now we're talking about 800 bandwidth or 800 megahertz system. The trunking or 800 megahertz systems assigns many frequencies, allowing the computer to constantly monitor for an open frequency. An interoperable communication system allows for all of the agencies involved to share valuable information with one another in a real time. This became especially important in the 9/11 incident because we had such a hard time being able to communicate with one another without an interoperable system. It would not have worked. Mobile data terminals or MDTs are inside the ambulance. They receive data directly from the dispatch center. They allow for expanded communication capabilities. For example, maps, how to show you where you're going. So, it's a Google Map type of thing without having to have Google Map. It's a mounted screen that's connected to the GPS on the unit that'll get you where you're going. Right. So, about radio communication specifically, it is the Federal Communications Commission, or FCC, that regulates all operations in the United States. The FCC has five principal EMS related responsibilities. They allocate specific radio frequencies for use by EMS providers. They license base stations and assign appropriate radio call signals for those stations. They also establish licensing standards and operating specifications for radio equipment used by EMS providers. And they establishing limitations for transmitter power output. They also monitor the radio operation themselves. The FCC rules and regulations, Section Part 90, Subpart B, deals with EMS communication issues. There is a test question that I see all the time. Does the FCC work on radios? No, they do not. They're not responsible for the maintenance of any kind of radio equipment whatsoever. That is a subcontract. I've seen that so many times, that question. Watch out for that one and make sure you don't answer yes on that one. All right, so responding to the scene. Here we go. Oh, woo, 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 woo. Right. Responding to the scene, the dispatcher receives first call to 911. Okay, it comes through a PSAP or public service access point. The responsibility of the dispatch is to properly screen and assign the priority of each call according to the predetermined protocols. Select and alert the appropriate EMS response units and then dispatch them directly as an EMS response unit to the correct location. Then they coordinate EMS response units with other public safety services until the incident is over. And they provide emergency medical instructions also to the telephone caller. Continue on with their responsibilities. We're talking about responding to the scene. The dispatcher assigns the appropriate EMS response unit based on several criteria. What is the nature and the severity of the problem? what is the anticipated response time to the scene, levels of training of available EMS response units, and the need for additional support. The dispatcher should give the responding units the following information at minimum: the nature and severity of the illness, injury or illness or incident, the exact location of the incident, number of patients if known, and responses by other public safety agencies, and any special directions or advisories such as adverse road or traffic conditions or severe weather reports. And then all take care of all of the times that the units are dispatched. Right. So EMTs report any problems that took place during the run to the dispatcher. EMTs inform the dispatcher upon arrival of the scene. Arrival reports should include any obvious details observed during the scene size up. And radio communications must be brief and easily understood. Speaking in plain English and do not use any code words. Report only the pertinent, important information. Right. So communicating with medical control and hospitals. So communicating with medical control is pretty simple business. It's the principal reason for this radio communication is to facilitate communication between you and medical control and the hospital. Medical control may be located at the receiving hospital, in other facility, or sometimes even in another city or state. Do not be confused with medical control versus, your medical direction. Two different entities. Medical control is usually that receiving facility or receiving hospital or a standalone facility that will relay the information through to the correct hospital. So don't be confused about medical direction and medical control. They're two different entities. All right, so consulting with medical control serves several purposes. It notifies the hospital of an incoming patient, and it provides an opportunity to request advice or receive orders from medical control. It advises the hospital of special situations. You need to plan and organize your radio communication before you transmit. We've talked about this before. You need to have some kind of document that you're utilizing, an assessment tool, a radio report tool, a field tool, something, some kind of tool that you're going to have your radio transmission already organized and ready to go. So, giving the patient report. The report commonly includes the following 10 elements: your unit identification and level of services, any special alert indicated on the patient's condition, the receiving hospital and your estimated time of arrival, the patient's age and gender, patient's chief complaint, or your perception of the problem and severity. A brief history of the patient's current problem, a brief report of the physical findings, and a brief summary of the care that you have given, and a brief description of the patient's response to the treatment. And then finally, determine whether the receiving facility has any additional questions or orders. All right, so medical control. What is the role? Medical control is either offline, which is also called indirect, or online, which is called direct. Depending on how the protocols are written, you may need to call for medical control for direct orders or permission to conduct certain tasks, such as administering certain treatments, determining the transport destination of patients, or stopping treatment and or not transporting a patient. In most areas, medical control is provided by the physicians working at the receiving hospital. Many variations have developed across the country. In some areas, medical direction may come from a freestanding center or from an individual physician. Right, so calling medical control. There are a number of ways to control access on an ambulance to hospital channels. The dispatcher monitors and assigns the appropriate clear medical control channels, or they're centralized. A centralized medical emergency dispatch or resource coordination center is that you know what the selection frequency is, either by radio or by cellular phone. Your report must be precise and contain only important information. Never use codes when communicating with medical control unless you're directed to do so by your local protocol. Once you receive an order from medical control, repeat the order back word for word, then receive confirmation. Do not blindly follow an order that does not make sense to you. So, some information regarding special situations. You may initiate communication with hospitals to advise them of an extraordinary call or situation. In a small rural hospital, it may be better to respond to multiple patients from a highway crash if notified when the ambulance is first responding. An entire hospital system must be notified of any disasters. Other special situations could be hazardous materials, rescue in progress, or multiple casualty incidents. When notifying the hospital of special situations, keep several points in mind. The earlier the notification, the better. And also provide an estimate of the number of individuals who may be transported to their facility. And then identify any special needs that the patients might have, such as burns or hazardous materials exposure, because if they're going to have to be decontaminated additionally when they get there, that's going to help them to prepare. And then follow whatever your plan is for your system. Maintenance. Remember, the FCC does not do maintenance. Just a reminder, be careful of that question. Like other EMS equipment, radio equipment must be serviced. At the beginning of a shift, check the radio equipment. Radio equipment may fail during a run, so a backup plan must be followed. Standing orders, written documents signed by the EMS medical director should outline specific directions, permissions, and sometimes prohibitions regarding patient care when you don't have communications. When properly following, they have the same authority or legal status given over the radio. So, at these particular slide sets from here on out, this is slide number 94, and we'll go to 123, is some review questions. We're going to close here and allow you to go through these review questions on your own. And if you have any questions, you can bring this up with your instructor in class. I hope you have enjoyed this presentation. And I tell you what, I have, and I look forward to seeing you the next time. So have a great day and go over these review questions, and we'll discuss them in class.